Hi everyone, my name's Sam Connell, part of the chronic ischemic heart disease. My presentation will be on techniques used for assessing coronary blood flow and myocardial perfusion. We'll also be talking about the role that these techniques play in clinical assessment as well. So the contents and structure of the presentation. Firstly, we'll go over the objectives, what we want to achieve through this presentation. We'll define chronic ischemic heart disease, go over some key definitions, so coronary blood flow and myocardial perfusion, what they actually are, what do they mean, before we actually go into the techniques themselves. The assessment techniques, go through those, and for each one we'll highlight the role that they play in clinical assessment. And finally, the reference list. So the objectives, we want to define and clarify the term chronic ischemic heart disease. Also want to define coronary blood flow and myocardial perfusion and understand the influencing factors. It's important that we understand those before we actually go into the techniques used to assess them. So we want to describe the techniques used to assess coronary blood flow and myocardial perfusion and discuss their role that they play in clinical assessment. And also clinically analyse these techniques with reference to relevant scientific literature. So, what is chronic ischemic heart disease? It's often referred to as coronary artery disease, coronary heart disease, or cardiovascular disease. Specifically, chronic ischemic heart disease refers to the recurrent myocardial ischemia and stable angina that result from the narrowing of a coronary artery lumen due to atherosclerosis and/or vasospasm. So the lumen meaning the tube in the middle where the blood actually runs through of an artery. When that gets compromised with plaque, as we can see down the bottom, atherosclerotic plaque, or when the blood vessels actually constrict, they can both cause reduced blood flow. There's several major types of chronic ischemic heart disease. We have chronic stable angina, which is chest pain or discomfort that most often occurs with activity or emotional stress. Angina is due to poor blood flow through the blood vessels in the heart. We also have silent myocardial ischemia, so that is reduced blood flow and in turn reduced oxygen without angina or chest pain. Vasospastic angina is episodes of angina at rest, and they result from coronary artery vasospasm, so as we said, the constricting of the blood vessel. And ischemic cardiomyopathy. So that simply is the compromisability of the heart to do its job, and that is to pump blood around the body. If we can't have that, then it's obviously going to be problematic for everything else that's going on. So some definitions. We have coronary blood flow, also known as coronary circulation. It refers to circulation of the blood in the vessels supplying the actual heart muscle, so the myocardium. Cardiac tissue has one of the highest oxygen consumption rates per tissue mass in the body. It makes sense because it's going all the time, it's continually doing its job, it doesn't stop ever. So adequate coronary blood flow is obviously very important. Myocardial perfusion, very similar, but it's the physiological process of delivering blood to the heart muscle, so the actual deliverance of the blood into the heart muscle. Coronary blood flow and myocardial perfusion are interrelated. Okay, understanding coronary blood flow and myocardial perfusion. So, they're influenced by three main factors. We have aortic pressure, autoregulatory mechanisms, and compression of intramyocardial vessels by contracting heart muscle. So, aortic pressure, because the coronary blood flow and myocardial perfusion, they're at their peak during diastole, so when the heart's filling up. This is because the two main coronary arteries that supply blood to the myocardium, the heart muscle, they're positioned in the sinuses. And when the heart fills up, so during diastole, the aortic valve is actually closed, which means blood flows directly into the coronary arteries and aortic pressure is increased. The autoregulatory mechanisms, what we mean by that is when metabolic demands are increased, there are mechanisms that are triggered to assist in regulating blood flow through changes in the diameter of blood vessels, so vasoconstriction, vasodilation, an increase in metabolic demand is met with the triggering of vasodilators, which allow for increased blood flow in coronary arteries and therefore increase myocardial perfusion. And vessel compression during systolic contraction, cardiac muscle has a squeezing effect on myocardial blood vessels and also causes increased intraventricular pressure because the small blood vessels within the myocardium are being compressed. So as discussed earlier, like we just discussed it then, the opposite is true during diastole because the pressure is released and blood can flow back into these vessels once the heart is filling up, so it's not contracting. One thing that we need to mention though is heart rate increases, the time spent in diastole is shortened, so coronary blood flow and myocardial perfusion can be greatly reduced with increased tachycardia, so increased heart rate. It's important that we talk about that as we go into discussing the assessment techniques, because often in this exercise-induced ischemia, this is what's happening because of the shorter time in diastole, where we often get the ischemia happening in the heart. So the assessment techniques for coronary blood flow and myocardial perfusion, they include electrocardiography, so ECG, exercise stress testing, echocardiography, nuclear cardiac imaging, cardiac MRI and CT, and cardiac catheterization and angiography or arteriography. Electrocardiography, ECG. It's a testing procedure that records the electrical activity of the heart. 12-lead electrocardiogram is the most commonly used measure for diagnosing and treating coronary artery disease. It uses electrodes to record and visually interpret electrical impulses from action potentials during the cardiac cycle. It is important to note how important electrode placement is for obtaining ECG data. It can have a major effect on the amplitudes and axes of ECG, which often can be misinterpreted. Different exercise tests when using ECG. It's important to take into consideration what exercise tests you're going to do to reduce movement of where you're going to be putting the electrodes, because this can also affect the signals and data that you're recording. So ECG and chronic ischemic heart disease. So ischemic heart disease can manifest itself on an ECG by Q wave or ST T wave abnormalities during rest, or through ST segment depression during an exercise test. The severity or magnitude of ischemia caused by a coronary lesion is directly proportional to the degree of ST segment depression, the number of ECG leads involved, and the duration of ST segment depression in recovery, so how long it takes to get back to normal state. So the role of ECG in clinical assessment. It's significant in mortality and cardiac event prediction. So in a study by Das et al., fragmented QRS readings were examined as a predictor for cardiac events and mortality as a result of coronary artery disease. They found all-cause mortality and cardiac event rate were higher in the fragmented QRS group compared with the non-fragmented QRS group. So that meant with an abnormal QRS reading, there was a higher mortality and cardiac event rate. Fragmented QRS was found to be a significant independent predictor of cardiac events and is strongly associated with a lower event-free survival from a cardiac event on a long-term follow-up. So the next one, exercise stress testing. It's often used to observe the cardiac function of people, usually adults, with symptoms consistent with ischemic heart disease. It's also used to assess the physiological adaptations following a myocardial infarction or a heart attack. Used to assess an individual's functional capacity to perform an exercise test and undergo cardiac rehabilitation, an individual's capacity to undergo surgery, and the effectiveness of medication or surgery used to treat and prevent a cardiac event. It's also quite useful for determining whether a person is fit to go back to work after a cardiac event, and it's used in conjunction with ECG. So we need the ECG to pinpoint where maybe, for example, ischemic changes occurred. So an example of an exercise stress test is the treadmill test. It's one of the most commonly used CV tests or cardiovascular tests in the US. Typically requires a high level of myocardial performance, and the goal is for the client to reach the maximum level of exertion for their age if possible. Blood pressure and heart rate are monitored. An ECG pattern is recorded to detect any myocardial ischemic changes. So angina, dyspnea, so breathlessness, arrhythmias or ST segment changes, and hypotension, so low blood pressure, can indicate decreased coronary blood flow and myocardial perfusion, meaning that ischemic heart disease it's likely there. If one or more of these symptoms are present during the test is immediately terminated. So this slide is showing a nomogram, and it's a percentage of predicted exercise capacity in relation to age. So this particular one is for active women and sedentary women, active women being in red, the sedentary women being in blue. And how these work, there's a line drawn from the patient's age on the left-hand side of the scale to the MET value on the right-hand side of the scale, or the metabolic equivalent of task. So where the percentage line, when it becomes intersected, and that gives us the patient's percentage of predicted exercise capacity for their age. So you can see that active women, they have a higher predicted exercise capacity, percentage of predicted exercise capacity compared to sedentary women. So often exercise tests, the results of these, or pre-test is actually, they go off a nomogram. So cycle ergometry, it's another very common exercise testing mode. It's less expensive and requires less space than the treadmill graded exercise test. It's a good option for individuals who are obese or have orthopedic problems, joint problems if they're elderly, and peripheral vascular and neurological limitations. It can sometimes give more accurate ECG readings as well, and blood pressure because of the reduced arm movement and thoracic movement during testing. There is a downside though. Cycling may be more unfamiliar to a lot of people, and this can compromise results because the test can end prematurely due to localized leg fatigue, for example. They haven't used their legs to cycle for years and years. So yeah, compromising the data that we were able to get from that test. Arm cycle ergometry is a common testing mode for individuals who can't actually perform leg exercises, so paraplegics, amputees. So it can actually be modified to suit other populations as well. So the role of exercise testing in clinical assessment. So ECG abnormalities during exercise testing can be used as clinical indicators for the necessity of further testing, such as cardiac angiography, which can further determine whether a patient needs revascularization surgery, for example coronary artery bypass grafting, or sometimes referred to as CABG. Functional exercise tests are a valuable tool for assessing an individual's capacity to return to work, as we said before, after a significant cardiac event. Also highly popular in diagnostics, so widely believed that graded exercise tests, they're highly viable diagnostic tools for individuals with intermediate pre-test probability of cardiovascular disease. This is due to the dramatic impact that exercise responses has on post-test probability of the disease. Also useful for prognostic information. So it's useful for gauging disease severity among individuals with known cardiovascular disease. It's convincing evidence to support the prognostic ability of aerobic capacity in individuals with relatively high risk of developing cardiovascular disease. In a study done by Kadama et al., conducted a meta-analysis of more than 33 studies, telling more than 100,000 subjects. He found that estimated aerobic capacity from treadmill speed or level or ergometer workload was a consistent prognostic marker in apparently healthy men and women. Each one MET score increase in aerobic capacity reflected a 13% decrease in all-cause mortality and 15% decrease in cardiovascular events. So this really highlights the importance of exercise as a viable, not only a viable testing mode, but also as a treatment. Echocardiography. So it's a widely used diagnostic tool to assess the structure and function of the heart. Uses ultrasound technology which echoes. It's inaudible, but it's shown visually whenever there is a change in the resistance to the transmission of sound waves. It gives a detailed moving image of the heart as chest walls, blood and various heart structures affect ultrasound waves differently. It's highly useful for detecting abnormal valve movements, ventricular dimensions, diastolic and systolic volumes. There's several different forms of echocardiography. So there's M mode, which is the earliest form of echocardiography. It uses a stationary ultrasound beam to produce one-dimensional view of the heart. Two-dimensional imaging, as the name suggests, uses a moving ultrasound beam to produce an integrated view of the heart, and multiple pie slice, if you like, shaped images. The three-dimensional imaging, it's a more detailed image as well. Doppler ultrasonographic imaging uses ultrasound to record blood flow within the heart, and it's very specific to coronary blood flow. In contrast, echocardiography helps to delineate structures on the left side of the heart. So the role of echocardiography in clinical assessment, it offers a non-invasive assessment of diastolic capacity. So in a study by Nishimura in 1989, detailed the importance of clinicians being able to utilise Doppler ultrasonographic imaging to assess diastolic function without invasive interventions, without actually having to go into the body. It also gives clear assessment of coronary blood flow by measuring the inflow velocities among normal healthy patients and in disease state. So inflow meaning in diastole, so blood coming back to the heart. It's also very useful for prognosis. So according to Levy et al., the echocardiographic assessment of the left ventricular mass offers prognostic information beyond that of traditional risk factors. This information improves the ability of clinicians to identify individuals at a high risk of ischemic heart disease. So next we have nuclear cardiac imaging. It involves the use of radionuclides, or radioactive isotopes. It's non-invasive, and there's three major types. So we have myocardial perfusion imaging. It's used to visualise the regional distribution of blood flow within the heart. Myocardial perfusion scintigraphy uses a substance called thallium-201. So it's an analogue of potassium, and we all know how important potassium is for regular rhythm of the heart. It is distributed into the myocardium, and an external detection device measures how well the radioactive substance is distributed. Ischemia can be identified as a spot on the image that is not lit up, I suppose, and meaning radioactive uptake is lacking in that particular area, and can indicate abnormal function of myocardial cells, so the ability to uptake what's in the blood. PET scan, positron emitting tomography. So it uses positron emitting agents to demonstrate perfusion and metabolic status of the myocardium. During ischemia, the heart shifts from fatty acids to glucose metabolism. So by using a positron emitting agent that's derived from glucose, clinicians can actually see where the ischemia or reduced blood flow is occurring by observing the areas of persistent glucose metabolism. And thirdly, the radionuclide angiocardiography provides a clear visualization of ventricular structures during systole and diastole. It's a type of nuclear imaging and can be used to assess differences in volumes between the left and right ventricles, as well as measure ventricular wall movement, cardiac contractility and ejection fractions. So the percentage of blood leaving the heart during contraction. So the role of nuclear cardiac imaging in clinical assessment, again, it's a non-invasive test, which is very appealing to a lot of people. It's diagnostic, so two major diagnostic focuses. It provides a functional image of the hemodynamic consequences of coronary artery disease. It also provides a non-invasive anatomical imaging of the normal structure of arteries within the heart. Prognosis, it's an extremely effective tool for providing prognostic information when coupled with predictive clinical and exercise variables. Risk stratification, it's accurate and cost effective, and it's good for identifying individuals of intermediate risk of developing coronary artery disease. So people of high risk often bypass this type of assessment, but those at an intermediate risk, this is a good use for risk stratification. So next we have cardiac magnetic resonance imaging, so cardiac MRI and computed tomography. So cardiac MRI uses powerful magnets and radio waves to create pictures of the heart. Similar images are called slices in these, and they're used for measuring the mass, volume and function of the ventricles. Individuals implanted with pacemakers and defibrillators cannot receive an MRI. Computed tomography is an X-ray based technique that takes cross-sectional images of the body by rotating the scanner around the patient. For cardiac CT imaging, images can be taken both with or without the use of contrasting substance, so something that's injected into the arteries or up to the heart. So non-contrast CT is often used for coronary artery calcification, and a contrast CT is used to assess cardiac chambers, large cardiac vessels, coronary artery lumen, because it can be easily defined. They can look at the structure of the heart and the lines that delineate the different structures. Electron beam CT scans are developed specifically for cardiac imaging, and they're effective in identifying individuals with or at an increased risk of developing coronary artery disease. So the role of cardiac MRI and CT in clinical assessment, again, non-invasive. It's used in the detection of coronary artery disease. That's MRI we're talking about. It's a very effective method of comprehensive cardiac assessment. It's an important tool for assessing myocardial viability, that is abnormal contraction of the myocardium at rest due to ischemia, reduced blood flow. It's been called the gold standard for measuring cardiac chamber volume and function. It's often a go-to. It's useful for visualizing valvular function and for demonstrating higher resolution images of complex congenital and acquired cardiac and vascular disease processes. Particularly useful in diagnosing ischemic and non-ischemic cardiomyopathy in individuals presenting with ventricular dysfunction. So the role of CT in clinical assessment is increasingly used for non-invasive coronary angiography, highly sensitive and specific to detecting coronary stenosis. It's a useful diagnostic tool for assessing individuals with an intermediate risk of coronary artery disease, widely used for measuring and assessing coronary artery calcification plaque. So the degree of or progression of these calcified plaques is given a score. And in a study by Greenland et al., it was reported that the CACP score of greater than 300 was highly statistically significant and independently predictive of fatal or non-fatal myocardial infarction, compared with the score of 0. This makes CT intervention a viable tool for assessing an individual's risk of a future or impending heart attack. So cardiac catheterization and arteriography, it's our last one. It's widely used, it's an invasive procedure, and it's used to assess coronary artery disease. It involves the insertion of flexible catheters. They get passed through the great vessels and chambers of the heart. Angiographic studies conducted by injecting a radiographic substance, which can be contrasted against heart tissues. This allows fluoroscopic images of structures to be observed and filmed. Coronary arteriography involves injecting the radiographic substance into the coronary arteries, and it allows visualization of lesions within these vessels. It's used to assess the degree of narrowing in coronary arteries, and used to perform percutaneous coronary intervention for the placement of coronary artery stents and for determining whether or not CABG, as we mentioned before, should take place. So the role of cardiac catheterization, arteriography in clinical assessment, Doctors can use cardiac catheterization and arteriography to collect blood samples in the heart, to measure coronary blood flow and use that to indicate ischemia, measure O2 sats within different parts of the heart, and heart tissue biopsies. And the references are there. So in summary, we've explained ischemic heart disease, the different assessment techniques and their clinical role. And I hope you've enjoyed the presentation and learned as much as I did in putting it together. Thank you.